So my presentation today is about a collaborative model for enhanced elder care. As you can see, we have quite a few people that support the collaboration. We started off with about 3 of us, but that's us now. So CEDRiC is an innovative model of service delivery involving cross-sectoral collaboration and partnership between myself as the Nurse Practitioner Candidate in residential aged care, general practitioners in primary care, the emergency department at the local hospital who have specialised geriatric nurses working in that area. So to illustrate the model of care, you can see at the top, well actually the first people to start were the geriatric emergency department intervention nurses at the hospital. They were already started before I moved into the role within the aged care setting. So CEDRiC stands for the care coordination through the emergency department of residential aged care and primary health care collaboration. And the CEDRiC project is a research project which looks at the model of the combined models of care. So in the residential setting, I'm there as the health intervention project for seniors, so that's HIPS, and the GEDI is the geriatric emergency department intervention team. So what I want to do is just walk you through the journey and how we got to where we are now. Sometimes as you walk through a journey, it can be quite a lonely sort of process to start off with. Okay. So when I started, or before I started as a nurse practitioner candidate, I was working as a manager in the community care setting, and I identified that a lot of our elders in the community had a lot of difficulty accessing the GP clinics, and many of the GPs haven't got the time to do the home assessments. In some instances, we had people that were so unwell that they really needed hospital care, but they were refusing to go. So that for me was like, wow, we really need nurse practitioners in this area. So it was inequitable access to the healthcare, and I just thought nurse practitioner role would help bridge that gap. So I went forward to apply for a scholarship and was successful to get that through the Australian College of Nursing, which was fantastic. And the aim of the role would be then to look at how we might bridge the gaps, address some of the funding shortages in aged care whilst bringing in new skills, and taking some of the burden off the acute health sector. And as well, if we can, the icing on the cake would be to develop a sustainable model. Are there any NPs in the audience at the moment working in private sector as well? Yes? Oh, you know how tough the journey can be. Yeah, I just wondered if there would be many that could relate. Anyway, okay. So one of the other things, literature tells us that there are workforce shortages within the aged care sector, and they're going to get worse because of increased need into the future. So this was the advantage of the nurse practitioner role might help address that. Also, with the potential for Medicare billing in the private sector, that might help address some of the funding issues regarding having additional skills brought to the aged care sector. I was hoping to also extend the nursing career pathways in aged care. Sometimes, similar to what somebody said this morning, in aged care, people think it's somewhere nurses go when they're wanting to retire. But boy, it's a really dynamic role, and lots of skills are required to be pulled together in that setting. So I gradually wanted to change the attitudes about that, because sometimes aged care nurses are seen as the poor cousins of the nursing sisterhood and brotherhood for those that are male nurses. So what we had then was a vision. So I wanted to create a self-sustaining model of care, but how could that be achieved? And I guess it's always ingrained in me, the good old nursing process. So we'd already identified the need. We needed to plan an intervention, implement the intervention, and then assess the outcomes of that. So the planning phase began. The best way when developing a new plan is to talk through ideas with other people. So what I found was essential was to share the vision, talk to other people, try to help them see what I could see, and enlist like-minded positive people. So again, I've just put a list of the organisations that are contributing collaborators. So Sundale's the organisation I work for. University of Sunshine Coast has provided the research background for us. Sunshine Coast Hospital and Health Service with the emergency department, the Primary Health Network have been the key players. We have a university professor that's also supporting through Griffith University, as well as the Department of Health, Department of Human Services that have helped provide some funding, and Oz HSI, which is another newer one that's added onto the list. So with all of these people collaborating together, we were successful in obtaining additional funding for the current model of care, which is under research. So planning the intervention meant for me that I had to leave my permanent role and jump into a nurse practitioner candidate role, which didn't have any guarantee of ongoing support or continuity. So initially in the early stages, it was a bit like taking the leap of faith. And this little guy here that just jumping in, landing on a lily pad and not really knowing if you're going to have another lily pad to get across to the other side at the moment. So really shows you have to have the commitment to your vision. So in talking with the other people, we decided that the collaborative model was the way to go, because our elders don't just live in one area. Their health conditions take them right across from aged care, primary care, and the acute sector. So the collaborative care was the only way that we could follow their journey and support them across the sectors. So it involves myself as the nurse practitioner candidate working in Sundale, doing the advanced health assessments, and then addressing any acute illnesses as they come up as well. For those elders that do need to be transported to hospital, we can facilitate the transfer by providing good information about what the elder's baseline is, what the catalyst for the transfer to hospital was, and what the treatment goals of hospitalisation might be. Because we don't send people to hospital lightly, knowing that a lot of elderly people in hospital don't do so well, have increased falls, increased confusion, etc., and I'm sure you're all aware of that. So more specifically, the role of the HIPS NPC was to identify those elders most at risk through proactive and reactive assessments and care, identify any red flags. Like one of the nurses asked me once, this lady's wound, or this tiny little break on her skin, it's oozing so much fluid. Really what the problem was, yes, she had fluid in her legs, but of course she'd gone into heart failure. But it wasn't at a point where it was upsetting her breathing too much at that stage, so they hadn't really looked that far into it. But listening to the lungs, you could hear the crackles. And early identification of any deterioration. So had to also build relationships with the key stakeholders, which included not only the clients and their families, the nursing staff, the carers, the GPs, the practice nurses. Gosh, you guys are great gatekeepers. Do a great job with the GPs. And then also, the hospital staffing as well, and emergency department staff. We have to develop the collaborative practice, be a change agent, educate additional team members or the care staff or the registered nurses. One of those ways is there's a stop and watch tool available that helps identify early deterioration for carers, and it allows them to put their finger on the problem so that they know that it's something worthy of reporting. So just implementing little tools like that within the organisation. And then through that process, upskilling the staff and also contributing to policy development. So being a change agent, and I'm sure it sounds like everyone in here has probably done that at some point, but it's a bit like being the elephant in the room. Everyone can see it, but no one really wants to acknowledge it. And I often think of Lewin's change management model, where you've got to unfreeze the current situation, implement the changes, and then solidify them into place through that process. So if you have to be cognizant of the emotions that people go through when undertaking any change process, particularly people that have got very ingrained processes already that, they've been working for many years in a certain way and don't see why it needs to change. So if you recognise what stage each individual person's going throughout the change process, you can help manage that process along the way. So when they're in that denial phase, if you can create alignment by helping to, share the goals, and it's not anything that's going to be a personal affront to them, it's just that we want to improve services for elders generally. And the frustration that can occur when people are trying to deal with new changes and concepts, and even a depressive state. And this is where we really need to flounce that vision and spark motivation. Once they've decided to take that initial engagement and move forward, we can really have the chance to develop the capacity and through shared knowledge, use them to help integrate the changes into place. So I liken this particular part to, has anyone ever had their mother-in-law come and stay for a week or two? And they're very, very helpful, and on the one hand you're grateful that they're doing jobs for you, but on the other hand it makes you feel a bit inadequate that you haven't had a chance to get to it yourself. That's kind of, I think, how the nurses felt when I first started on the wards, and remembering, or on the aged care wings, remembering that I came from the community sector, so I wasn't really one of their teammates as such. I came from an outside perspective, even though I was within the organisation, so probably felt a bit like that for them. So we secured the funding for the initial nurse practitioner candidate role for 12 months, which over that 12-month period, when we did a staged process with implementing the service. So initially for the first 6 months started in the high care section, and then brought on 2 more low care facilities and then another 2 more low care facilities. So it's just over 100 elders in the first section. And the differences that you can see from the hospital bed day numbers to the post was most marked in the high care section initially, but then the results were kind of watered down when we added in the low care facilities. And I guess I went from servicing like around about 100 elders to over 300. So you would expect some dilution over that period. But the other thing is that because of advanced care planning and such, a lot of the high care elders, we'd already had those in place, or facilitated those fairly quickly if they weren't already in place. A lot of the ones in the lower care facilities, even though they might have advanced care plans in place, they still want that choice to go to hospital. Of course, everybody has that choice to go to hospital, but more of them were at the stage where they wanted more active treatment within hospital settings. So therefore, the results were a bit different when you look at the aggregated data. But what this did do was provide information for a more detailed scoping, more detailed research study. So you can see when I was looking at just the high care results for the 12 or 13-month period, there was 23% reduction in the hospital presentations. I think before we included the low care or started servicing the low care areas, it was up around 40%. So it did drop down quite a bit. And then the bed days were, 46%. 46? Yep. Less for that period of time. But then when we added in all of the additional 200 elders from the lower care facilities, you can see the differences were quite a lot lower. But it was still a bit of food for thought and worth investigating further. So with that scoping study in mind, we did apply for additional funding, and we achieved that through the Department of Social Services. They gave us the formal funding for the CEDRiC project. So private sector nurse practitioner role. There are limited opportunities from my observation in the private sector. So in the tradition of nurse practitioner roles, it really comes about when you've identified that there's a service gap and you build that role from the ground up. And that's really what I've had to do. I don't know if the other ladies found the same situation yet. And there's even less opportunities for nurse practitioner candidate positions because they don't have that opportunity for Medicare rebates. Now I've explained that already. We submitted that grant application for the Department of Social Services, but it was still a while before we knew if it was successful. And I was just wondering at that point whether I had talked myself out of a job altogether. So it was a bit scary. Felt a bit like this. Pushing really hard uphill. When you get to the top of the hill, you don't know if there's a cliff on the other side or if you're just going to coast along for a while. So it's been quite a dramatic journey. I'm cognizant of the time, so I'll skip over the next two, but it's really about the business case that Heather Henry was talking about earlier. So I've got a little bit about the Medicare rebates for nurses and GPs, and we've just seen in the new budget that there's Medicare freeze until 2020, so that's not going to improve anytime soon. So I'll just skip over those, but if anyone wants me to go through that with them afterwards at lunchtime, I'm more than happy. So in advancing the profession, what we really needed to do is improve the general public understanding of nurse practitioner roles, but also increase our peers' knowledge of the nurse practitioner's role, because they are still quite grey, I suppose, because each nurse practitioner, as I said, the roles sort of emerge in areas where there's been a need, so they're all quite different in how they're implemented. You need to demonstrate the benefits, so the things that we were talking about, so that attracting more nurses to the workforce, improving elder healthcare, upskilling the staff that are in existing roles, and changing those attitudes. So looking at the improved clinical outcomes, organisational reputation, and being able to, with the formal research, present the business case to the government. So looking at reducing the hospital presentations, it's great for the hospital, but it doesn't actually save the residential aged care side any funding. So it's a way of, at the moment, it kind of cost shifts the cost to the residential facility. The early financial review I've had with Medicare billing, if I was potentially billing through Medicare now, it doesn't look to be sustainable at the moment, the way I'm doing things. Other people may have more effective ways of doing it, but at the moment it would still require quite substantial organisation support, which I was a bit deflated about. So where to from here? Endorsement. Well, I submitted my endorsement just a couple of weeks ago and it came back a week later, so I'm in. But my job title still says Nurse Practitioner Candidate, so I still can't practice in the full role until the organisation has decided whether they're going to offer the permanent role, but hanging in the balance, so we're nearly there. And again, then looking at the sustainability, we have to be business-minded about things as well, much like what the GP clinics are run. I could learn a lot from working with you in the clinics because I've never had to deal with Medicare billing before, so that's a new one. We may be able to secure additional funding to have some ongoing research. And then general acceptance once the nurse practitioner role has evolved. There has been some research that once you turn into nurse practitioner that GP relationships can go downhill a little bit, but I don't think so with the guys I'm working with. They've been fantastic and seem to be really supportive and looking forward to it. And I'll bring to a close now and just say special thanks to the CEDRiC research team. So we've got Professor Marianne Wallace and Elizabeth Marsden. Marianne Wallace is heading the research. Elizabeth Marsden was my mentor as a candidate and also the Geriatric Emergency Department Specialist at Nambour Hospital. Andrea Taylor, one of the GEDI nurses, and a multitude of others we have there, and also my co-workers who have been a pillar of support throughout the process. So I couldn't have done it without them. Would have probably given up and faded away by now. So thank you very much. That's all I have to share today.
Any quick questions? Hi, how are you going? My name's Amy Bowen. I'm a nurse practitioner in aged care in Sydney. I am not only in the private sector, but I'm self-employed. So I have absolutely no of the foundations that you have in place. I just wanted to say congratulations on your NP. It's a huge achievement and well done on the work you're doing as well. I wanted to ask how you found the other GPs working in the aged care facilities, how they've taken you on, and also just to let you know, sustainability of your role out there is 100% viable. Don't be put off by putting it into Medicare right now. Speak to me after this.
Okay, I will do.
Trust me, I do it out there on my own.
Yeah.
And I have collaborative agreements with 5 different GPs. I look after 350 patients, very similar. This is doable, trust me. So how did you find the GPs approached?
They've been fantastic. Look, even one of the GPs said he thinks I could do 90% of the tasks that they do already. And when you think about a lot of the work that they do over faxes and phones that they're not reimbursed for, I could take that workload from them. So they're really looking forward to me coming on board and for the role being continued through the organisation. So there's about 28 GPs that work through the residential facilities, so there's quite a few, but I haven't had one negative. I shall escape.
Thank you. So thank you, that's amazing, and congratulations. I think a big round of applause as congratulations. Thank you for your presentation.